This is a chest radiograph of a young man with myasthenia gravis who presented with hypoxia. The initial film shows a retrocardiac opacity with visible air bronchograms and narrowing of the intercostal spaces on the left, indicating volume loss. The left hemidiaphragm is not seen behind the heart, and the left heart border appears abnormally straightened. The left hilum is displaced inferiorly. These findings are characteristic of left lower lobe collapse, most likely secondary to a mucus plug. On the follow-up film taken the next day, there is near complete resolution of the opacity. The left hemidiaphragm is now clearly visible, and the left heart border has regained its normal curvature, confirming that the collapse was due to a reversible obstructive cause. The peripherally inserted central catheter is incidentally noted to have flipped into the left brachiocephalic vein. The main differential diagnosis for this appearance is left lower lobe pneumonia versus collapse. However, the presence of significant volume loss, indicated by rib crowding, diaphragmatic elevation, and hilar displacement, strongly favors collapse. Left lower lobe collapse typically produces a retrocardiac triangular opacity, with the base of the triangle obscuring the left hemidiaphragm and the apex pointing toward the hilum. Because the left upper lobe remains aerated, the left heart border is preserved, but the cardiac silhouette may appear straighter than usual. This has been described as the flat waist sign. Volume loss leads to leftward rotation of the heart, making the frontal projection mimic a right anterior oblique appearance. Other associated findings include lingular linear atelectasis, known as Nordenson's sign, which results from altered bronchial orientation and hyperexpansion of the upper lobe and shift of the anterior junction line or the top of the knob sign, where the mediastinal soft tissues obscure the aortic arch due to the collapse. In terms of management, the mainstay of treatment for simple lobar collapse is pulmonary toilet, encouraging airway clearance through physiotherapy, incentive spirometry, and occasionally bronchoscopy to remove a mucus plug. If there are no prior imaging studies for comparison, follow-up is important to ensure complete resolution, as persistent collapse may indicate an underlying obstructing lesion, such as a central bronchogenic carcinoma. In summary, this case demonstrates a left lower lobe collapse secondary to mucus plugging, showing the classic retrocardiac opacity, flat waist sign, inferior hilar displacement, and volume loss, with rapid resolution on follow-up, confirming its reversible obstructive nature.